At first, the scale moves. Hunger gets quieter, portions shrink without much effort. Then a few months later, weight loss slows, appetite gets louder, and panic walks in. It stopped working. But did it really? Or did something less dramatic happen instead? Because when people say Ozempic stopped working, it usually means one of four things: a normal plateau, a dose that hit its ceiling, behavioral drift, or a mismatch between the drug and the goal. This is not medical advice. Consult your doctor. In many cases, Ozempic has not truly stopped working. What people often mean is that the fast, obvious phase is over, and the biology behind each of those four situations starts showing itself. I'm Dr. Kim. Let's break it down. Situation 1. The medication is still working, but the body has adapted to a lower weight. Situation 2. The dose reached its ceiling before the goal was reached. Situation 3. The drug is still suppressing appetite, but the body found ways around it. Situation 4. The treatment was never strong enough for the size of the goal. A plateau is not the same as failure. When body weight drops, the body changes. A smaller body burns fewer calories at rest. The same food intake that once produced weight loss now produces maintenance. This is not a malfunction. It is the body defending a new normal. That is the moment people often say, "It worked for 3 months and then stopped." What really happened is that the steep part of the curve ended. The drug is still doing its job. The target just moved. There is also a hormonal layer to the plateau itself. As body weight falls, levels of leptin, a hormone that signals fullness, tend to decrease. At the same time, ghrelin, which drives hunger, can rise. Some people are using the wrong benchmark. Weight loss is usually uneven. There are faster weeks, slower weeks, flat weeks, and occasionally a week where the body seems to be reviewing the contract. Expecting a straight downward line is a reliable way to misread a normal result as a failed one. Weight loss is not the only valid signal. If appetite is still better controlled, overeating is less frequent, and weight is being maintained rather than climbing, that may not be glamorous, but it is not nothing. Beyond the scale number, the composition of what is being lost, fat versus lean mass, matters as much as the total amount, the dose ceiling. With semaglutide, the early phase and the long-term phase rarely feel identical. Appetite suppression may feel less dramatic after several months than it did in the first few weeks. Part of this comes down to individual biology. Research suggests that receptor sensitivity, baseline insulin resistance, and the way each person's brain processes food, reward signals all influence how strongly the drug works, and how long that effect stays at full intensity. Two people on the same dose can have meaningfully different experiences, and neither response is wrong. Sometimes the dose also hits a practical ceiling before the goal is reached. Tolerability limits how high the dose can go. If the effective ceiling for a particular person is lower than the dose required to reach their goal weight, that gap is not a failure of the drug. It is a mismatch between biology and expectation. When that ceiling becomes a real obstacle, switching to a different agent is sometimes worth discussing with a clinician. Tirzepatide, for example, works through two pathways rather than one, targeting both GLP-1 and GIP receptors. For some people who have plateaued on semaglutide, that dual mechanism produces additional weight loss. That is not because one drug is universally superior. It is because different receptor profiles interact differently with different bodies. The biology is specific to the person, and the treatment should reflect that. Behavioral drift is the quiet one. In the early months, the drug's appetite suppression is strong enough to override old habits. Later, the suppression may still be present, but habits start finding their way back. The brain, it turns out, has a very long memory and a very short attention span for deprivation. Portion sizes drift upward gradually, a second helping that feels justified after a long day. The body's calorie compensation systems, which were temporarily quieted by the drug, begin reasserting themselves. This is metabolic adaptation, not moral failure. Environment plays a role too. Social eating, alcohol, stress-driven food choices, and irregular schedules can all accelerate drift. The drug suppresses the internal hunger signal. It does not suppress the external environment. And over months, the external environment often wins ground back, not all at once, but enough to flatten the curve. A useful way to distinguish between genuine appetite return and behavioral drift is to run a simple mental check. If hunger feels genuinely stronger, earlier satiety is gone, food noise is louder, cravings are more insistent, that points toward the drug's appetite suppression weakening. If hunger feels roughly the same, but portion sizes and food choices have quietly shifted, that points toward drift. Sleep and stress are part of the same external environment the drug cannot suppress. Poor sleep raises ghrelin and lowers leptin independently of what any medication is doing. Chronic stress elevates cortisol, which promotes fat storage and increases appetite, particularly for energy-dense foods. If sleep quality has deteriorated or life stress has increased around the same time weight loss slowed, that timing is not a coincidence. It is a signal worth bringing into the clinical conversation. The treatment was never sized for the goal. If someone is aiming for major weight loss, but the actual treatment plan was never strong enough for that goal, the realistic limit may simply be lower than expected. That is not the drug falling short. That is the plan being too small for the goal. Research suggests that semaglutide typically produces meaningful but finite weight reduction, enough for some goals, not for all. And when that gap exists, the honest next step is a conversation about the plan, not a conclusion about the drug. One question still comes up. What happens when someone stops? Research suggests that after discontinuation, appetite tends to return, and weight often climbs back, sometimes substantially. This is not drug failure, it is a sign that the underlying biology has not changed and the medication was managing it. Stopping because the scale stalled is a different decision from stopping because the clinical picture warrants it. For people who stopped and want to restart, research suggests the medication can still be effective, though the restart conversation is worth having with a clinician. The four situations share the same visible result, but point in different directions. Identifying which one is actually driving the picture is what makes the next step concrete. A plateau means the body adapted, not that the drug quit. Behavioral drift is the nervous system reasserting itself, not a character flaw. A dose ceiling is a biology problem, not a willpower problem. And sometimes the plan never matched the biology. When Ozempic seems to stop working, it often has not truly stopped. What looks like failure is usually one of four things: a body that adapted to a lower weight, behavioral drift that crept back in, a dose that hit its ceiling, or a plan that never matched the biology. The useful question is not, did it stop working, but which of these four actually happened? That answer points to the next step. Medicine simplified. That's what this channel does. If you want more, hit subscribe. This is not medical advice. Consult your doctor.